When I
Yeah, not last week, the week before, we had Dr. Kimball on talking about mental health and stuff.
Oh, Hillary was there. Oh, nice.
Yeah, she was there. She did a great job.
Oh, she's
Alrighty.
wonderful.
Oh,
All right,
absolutely.
Maritza, I'm turning it over to you, and we are up and running on live.
Are we still in practice session?
We are still in practice session, but we are on live. So you got to come on a practice session.
Okay, sounds good. I'll start. Alrighty. Just make sure I can see everything. Alrighty. All right, well, hello everybody. Welcome back to our 2025 Summer School Webinar Series. My name is Maritza Vaya. I am the Mental Wellness Program Coordinator here at EFTX. And today, topic is going to be about medication management and treatment advances. And I'm excited to introduce our speaker this evening is Dr. Tyler Terrill. Dr. Terrill is a North Texas native who grew up in McKinney, Texas. He earned his undergraduate degree from Texas A&M University and went on to complete medical school at UT Southwestern Medical Center. He completed his pediatric neurology residency at Children's Medical Center and UT Southwestern, followed by his fellowship in clinical neurophysiology with a focus in epilepsy. Currently, Dr. Terrill serves as an assistant professor at UT Southwestern, primarily practices at Children's Health Plano and Children's Health Prosper. He is also actively involved in medical education as the Associate Program Director for the Pediatric Clinical Neurophysiology Fellowship Program at UT Southwestern. All right, and with all that being said, I'll turn it over to you, Dr. Terrill.
Awesome. Thank you. So, welcome everyone. I'm excited to be here. And we're going to talk about just the various treatment options for epilepsy. I have no disclosures, financial disclosures. However, I will be talking about off-label uses, in part because I'm a pediatric epileptologist, and so most of what I do is off-label. So just an outline, we're going to take about 2 minutes and go through like just the history of epilepsy treatment. We're then going to talk about medications, diet therapy, surgical therapies, and finally end with neuromodulation. So let's talk about early treatments of epilepsy, just to kind of show everyone how far we've really come. So originally, the original treatments of epilepsy was something called trepanation, which is basically where they would try and let out the demons in people's brains. And this was practiced for thousands of years, and in some places they still do this. Hippocrates, if you've ever heard of the Hippocratic Oath, he really advocated this, and he was the first one to recognize that, or one of the first documented to recognize that seizures are coming from the opposite side of the brain as where the problem is. So that's where he said to let it out. And for hundreds and thousands of years after that, even up until the Renaissance, people thought that seizures were an overabundance of phlegm in the brain, and which then led to other people suggesting certain kind of diet therapies, namely eating hot and dry diets to try and dry out the phlegm on the brain. And this was part of their kind of healthy living protocol for epilepsy that was often used in Roman times. Ancient religious leaders of multiple religions would advise fasting, which would actually induce ketosis. And we're going to talk about keto diet in just a little bit. And then early epilepsy surgeries actually started in the 1880s. In France, they started removing scar tissue from people who'd had head injuries to try and treat seizures. It was around this time also that some of the first surgeons started removing brain tumors, in which case often then they found patients stopped seizing when the tumor was gone. And then finally, we have medical therapy. So bromide salts bromide was a sedative. And in the Lancet, which is a famous journal, they described treating hysterical epilepsy in women with bromide salts. And kind of based on that description, we might now call that menstruation-related epilepsy, or catamenial epilepsy. And it was it was somewhat effective. But honestly, there was no new medication advances made up until about 1912 when Bayer, who makes aspirin, put phenobarbital on the market, which was also sedating, but much less so than bromide, and was kind of the start of our drug era of treatment. So, like I said, we're going to kind of walk through each of the treatment options. The first one we're going to talk about is medications. Keep an eye on the time here. Hope we're doing good. So this is just kind of a history of how we've been developing medications. As you can see, we have bromide way down at their bottom, phenobarbital. The first kind of, all seizure meds can be a little sedating, but the first one with less sedation was this one here, phenytoin, in the kind of, I think, 1940s. A lot of these older first generation drugs had a lot of side effects. There's a reason that most of you are not going to recognize a lot of these. It's because they're not used very much anymore. We started getting into second generation drugs, and a lot of these are sort of the tried and true. If you look at old research on epilepsy, they actually, a lot of times they're mentioning these drugs here, things like valproate, which is Depakote, or carbamazepine. You know, diazepam is Valium. And that's what people used to use. And then we started getting into the third generation drugs, and you can almost divide this in two. You've got kind of your early third generation drugs, which are some of the more commonly used drugs now. Things like levetiracetam, which is Keppra, oxcarbazepine, trileptal, zonisamide, lamotrigine. These are some of our most common drugs. And then you get to and then we're still developing new drugs now. Cenobamate is kind of the bigger breakthrough of late. Fenfluramine is back on the market. It used to be part of a weight loss drug in the 80s, caused a whole bunch of problems, but now it's kind of back and used for seizures now. And so we know that a lot of, and so these are a lot of times used more in genetic epilepsies, these kind of newest medications. And so again, this is a list of some of these more commonly used medications. Again, kind of a mix of second and early third generation drugs, most of which have decent side effect profiles. Keppra is probably the most commonly used medication in America, mostly because it doesn't interact with anything else. You can start it in the ER in a place that doesn't have a neurologist on staff. You almost can't overdose on it, to be quite honest. Versus Depakote, which worldwide is one of the most common because it can treat just about any seizure type, okay? But it has a little more risk of side effects. You've got what we call our sodium channel meds like Lamictal and Trileptal and Lacosamide, which are very good for treating focal seizures. Medications like Zonegran or Clobazam are a little more broad spectrum. And then ethosuximide is mostly used in pediatric epilepsy because it treats absence seizures, which are more common in children. And then we've got our newest medications. And most general neurologists are not using these, all right? Usually you have to go to an epilepsy center for these drugs, with rare exception. And these are kind of, at this point, really, there's some limitations on prescribing them. For example, Epidiolex is cannabidiol, right? And so a lot of people worked really hard to bring a spotlight on cannabis products as a treatment for epilepsy. And so then Jazz Pharmaceuticals saw that happening and created a kind of a purified form of CBD oil, which is approved by the FDA, and is approved for these syndromes, Lennox-Gastaut, Dravet, and TS. But as of about a couple months ago, more and more insurance companies are starting to allow us to prescribe it for other intractable epilepsies, which is really exciting because that was a really big fight for a long time. Ganaxolone has been approved for CDKL5 epilepsy, but I also know that it's being studied currently for use in the hospital for refractory seizures that are ongoing called status epilepticus. Fenfluramine, again, I mentioned earlier, was that kind of old weight loss drug that's now come back. It requires routine heart monitoring, but it shows a lot of promise and is currently being studied, and we're trying to get expanded use in conditions like Dravet and Lennox-Gastaut syndrome. And then finally, cenobamate. Right now it's approved in adults. There are multiple ongoing trials for kids, however, and for generalized epilepsy, right? There's a difference between a focal seizure, which starts in one part of the brain and spreads out, versus a generalized seizure, which is both sides of the brain at once. And so right now it's approved for focal, but I personally use it off-label for generalized epilepsy. And of course, I'm a pediatric epileptologist, so I'm using it in kids off-label. And it's probably, again, in my personal experience, it's one of our more powerful drugs. I've had a lot of patients fail many other drugs and have success with that. Same thing with fenfluramine as well. And so let's talk about some new trials happening with anti-seizure medication. Let's see time. Oh yeah, we're doing good. And so there's a medicine called lorcaserin, which modulates serotonin. And that's kind of important because there's not many other drugs that work on serotonin for epilepsy. Fenfluramine is the only other main drug that works in that pathway. So it'd be kind of, I'm actually really excited to maybe see another drug similar to fenfluramine hit the market. It's past its initial phase 3, and now they're kind of rerunning it with some expanded indications, specifically for Dravet syndrome and refractory epilepsy. Clemizole is another one being studied for Lennox-Gastaut and Dravet. This actually is an antihistamine, which is kind of interesting because that's not a mechanism that people are currently using for seizures. Something of the antihistamines are actually associated with seizures in overdose settings, and so it's actually kind of interesting. Getting new mechanisms allows us to mix medications in new and interesting ways. So seeing new mechanisms like serotonin, histamine blockers is really exciting. I mentioned fenfluramine is being trialed for earlier age use. Right now it's 2 and up. I think they're trying to get it for 1 and up, as well as use for infantile spasms. Basimglurant is being studied for tuberous sclerosis, and that modulates the glutamate pathway. All these are just various receptors on the surface of neurons, right? Trying to change the way neurons send their electricity. And glutamate is an excitatory chemical for neurons. And then this one is kind of so new, it doesn't even have a name yet. It's just this long string of letters and numbers. And this is in trial for SCN8A and SCN2A related epilepsies. And so these two conditions are both mutations in sodium channels, where the sodium channels in the brain are overactive, and they cause very, very severe life-limiting epilepsy. And so this is a sodium channel blocking medication that targets these specifically. And so that's really exciting. If you look at this, you're going to say, why is everything being studied in Dravet and Lennox-Gastaut syndrome? And it's because these populations have some of the highest burden of seizures. And so when a drug company is trying to decide, well, how am I going to run a trial? You want to run your trial on someone who sees a lot so that you only have to run it for a few months instead of a few years. And so the way a lot of these drug approvals work is sometimes they're approved in adults, in which case they're just approved. Other times, especially if they're trying for a pediatric indication, it generally starts in Dravet and Lennox-Gastaut syndrome because they're going to get a lot of seizures and then hopefully see a reduction within a couple months. And then eventually over time, we start getting insurance companies to allow us to prescribe it to other populations. And so if you're wondering, why is it all this Dravet, Lennox-Gastaut, tuberous sclerosis? It's for that reason. And then to me, some of those exciting things happening is in genetics. So within pediatric neurology and neurology in general, genetic testing has exploded in recent years. If you or someone you know has epilepsy, many of you, especially if it was pediatric onset, may have gotten genetic testing. And the reason is that we know that as we've expanded our knowledge of genetics, we're hoping to find ways to tailor medicine to the patient, to their specific mutations. And there's kind of 2 exciting things happening. One is gene therapy, which is amazing, right? The Endeavor trial is a gene therapy for Dravet syndrome. So Dravet syndrome, we already mentioned it has a lot of seizures. It's an SCN1A mutation, so a different type of sodium channel mutation. And the way this works is they have healthy genetic material instead of the mutated SCN1A gene. They package it up in this virus called AAV, adeno-associated virus, and then they infuse the virus into the patient. And the thing about AAV is most adults have been infected with AAV, but we didn't even know it because it doesn't really cause symptoms in humans. And so they pick viruses that don't cause symptoms in humans, And then they use that to try and infuse the gene therapy. Now, gene therapy is not without risks, right? In order to get your body to actually uptake that material, they have to give you such a high load of the virus that there are risks to like your internal organs. So it is not, so it is the kind of thing that requires very careful monitoring. But in theory, if it works, it's a one-time treatment and then you're cured. Or if not 100% cured, you're like 80 or 90% cured, right? It's rare for these therapies to be perfect, but they can be life-changing and life-saving. And so they're running phase 1 and 2 trials in that now in the US and I think UK as well. And then for a couple different things like Lafora syndrome, which is a progressive degenerative epilepsy, and again, SCN2A related epilepsy, there's some very early stage work going on in a couple of universities looking at antisense oligonucleotides. And this is a genetic related therapy. It is not real gene therapy. So the idea of an antisense oligonucleotide is it's a small protein that actually binds to and affects the DNA, and it affects the way that DNA is expressed. And so it can both kind of tamp down or ramp up. It can tamp down disease genes and it can try and ramp up healthy genes depending on how the oligonucleotide is developed. And so again, this is not a cure. This would be a routine med for people. But until we can get to the point where we're really offering gene therapy cures, the antisense oligonucleotides offer a great kind of band-aid for it, right? It can really affect the disease course. And we know that because they use these drugs in Duchenne muscular dystrophy, which has had antisense oligonucleotides for years, which have really expanded people's lifespans and really changed the course of that disease. And they're just now getting into gene therapy for that condition as well. So really exciting stuff, still in the very early phases though. Oops, is that? All right, I forgot that. So let's talk diet therapy for a minute. So you may have heard of something called keto, and you hear a lot of people talk about keto, right? You might hear people at the gym talk about keto to try and like cut excess, get lean or whatever. And that's fine. There's all sorts of keto cookbooks and keto this and that, but real medical keto is a little different. It's our most intense diet therapy, and what it is a very, very strict ratio of fats to sugar. All right. And so you might start at like a 2-to-1 ratio, then 2.5, go to 3-to-1, 3.5, 4-to-1. At our center is our most intense ratio. You have to be very careful to monitor protein intake. You have to monitor acidosis in the blood. You have to monitor all sorts of micronutrients. And it does come with risk. Pancreatitis, kidney stones. You can get too high of cholesterol or triglycerides. But 1/3 of patients go seizure-free, and another 1/3 have a significant reduction in seizure burden. And those numbers are better than just about any medication on the market. All right. And a lot of times, patients are on it for, say, on average, about 2 years. If they went seizure-free, they have a very good chance of staying seizure-free when they come off the diet. Not guaranteed, but a lot of patients do stay seizure-free, which, if you had intractable epilepsy, is an incredibly powerful thing to think about, right? That you kind of suffer through this for 2 years and then you could be free. Again, there's a lot that goes into keto diet. This is generally done at an epilepsy center in conjunction with a specialized keto dietitian. And again, you just have to be really careful, like, with how you approach your everyday diet. And again, we usually only use it for about 2 years because it's hard to be on such a high-fat diet. And then we try and liberalize you. There are, however, less restrictive diets, okay? And so the kind of option one is the modified Atkins diet, where you might be taking 10 to 20 grams of carbs a day. And then even less restrictive is the low glycemic index diet, where you might be getting 50 to 60 grams of carbs a day. And so with the nice thing about these diets is they're a little easier to tolerate, right? You don't have to weigh out every gram of food that you eat. You're probably not having to drink heavy cream to keep your fat intake high enough, that kind of thing. And there's a really interesting paper several years ago out of Harvard where they compared the three diets, and they didn't show that any one diet was significantly better than the other. Now, in practice, most people recognize that keto diet is the most effective diet therapy. However, I have had patients on modified Atkins and low glycemic index go seizure-free. And the thing is, I mean, low glycemic index hardly ever doesn't require much lab monitoring at all. You have to do some lab monitoring in modified Atkins. And again, you can think of this almost like a stepwise pathway. Keto is definitely the most efficacious, right? Probably won't have the most long-lasting effects. But it is worth, if keto is not right for you because of other medical conditions you have, or especially if you are a parent of a child with epilepsy and you're like, there's no way I'm going to keep them from getting, any sugar at all, then this might be a really cool thing to think about and talk about with your keto dietitian. Could we try a less restrictive diet? Please don't take this as like dietary advice. No diet should ever be started without a dietitian. This is just kind of an illustration of what the diet kind of looks like. All right. And a lot of people think keto is all about eating meat. There's actually not all that much meat in keto. It's actually mostly things like fat, like mayonnaise and, cheeses and kind of things cooked with butter, that kind of thing. Let's see how we do. All right, we're good. So next, let's talk about epilepsy surgery. All right. And for a lot of people, surgery is scary. All right. I mean, and I get it. It's brain surgery, right? But at the same time, compared to medications or maybe anything except keto, epilepsy surgery can be curative. Now, it's not always curative, right? But it can be. And that's something that a lot of families wrestle with is, do I want to start this journey? And I say journey because it is a journey, right? Getting to the point of surgery is a long, long journey. You usually need at least one inpatient stay on EEG, and usually you've had multiple EEGs by that point. A lot of centers do something called a SPECT scan, where you're in the epilepsy monitoring unit, they take your meds away to induce seizures, and then while you're having a seizure, they inject a radio tracer to try and see where the seizure is occurring. There's something called a PET scan, which looks at the metabolism of the brain, because often the area of seizure onset has a low metabolism compared to the rest of the brain. There's MRIs. Some centers do something called a MEG, which is a magnetoencephalogram. And the idea is that, our skull filters out a lot of that electricity that we need to track seizures. But a MEG actually is almost like an EEG, but for magnetic fields. And magnetic fields are not stopped by the skull. So you can actually get data from much deeper in the brain, sometimes with the MEG. There's usually neuropsychologic evaluations to help us determine what risk there is that you will lose certain functions, because that's very important to understand that risk. And we also might use something like a functional MRI to try and tell, where does your language live? Where does your hand function live? Stuff like that. And so all this stuff goes into the evaluation, and then they determine what can we offer you. And so a lot of times we call all this stuff the phase one. It's the first phase of evaluation. And then a lot of patients do something called a phase two. And so phase two looks a couple different ways. This is a picture of a stereo EEG. And the idea is, especially for seizures that we think are coming from deeper regions of the brain, right? Your brain has lots of folds, and some of those folds go pretty deep. And our scalp EEG may not pick it up. And so the idea is, you and your epilepsy team and your surgeon and your radiologist and everyone sit together and figure out, where do we think, based on all that data from all these tests, where do we think the seizures are coming from? And then you actually implant electrodes to try and find it, right? Each of these dots on those electrodes is an EEG, is a tiny, tiny EEG lead. And basically the surgeon makes little burr holes in the brain, inserts these leads, and then just like before, you go to your epilepsy monitoring unit, take some meds away, and they induce seizures. It's not always successful, right? Because, basically you have to have an educated hypothesis based on all your phase 1 data. But even then, if that hypothesis is wrong, you may not see the seizure onset. And this is this is the more common approach now here in America. But some patients still get the older approach, which is grids and strips. And in this approach, what they do is the surgeon actually will cut a flap of the skull, lift it off, and almost place like a giant sheet of, not giant, it's about that big, sheet of plastic with a bunch of little EEG leads on it and slap it on the cortex. And the idea is that, again, based on your phase 1 data, you already have a hypothesis of where the seizure is coming from. And then you put this on here. If you think that the seizure is coming from the outside and not the inside, grids are probably better than stereo. So there are times when grids are still appropriate based on your hypothesis. And both stereo and grids allow you to do something called mapping. And so the idea of mapping is, you can give a little shock and see if it affects the function. For example, if I give a little shock and you feel a tingling in your hand, well, I know that I just shocked the area for hand sensation. And you can map out things like language and hand function and foot function, the things that are really, really important. And grids are actually really good for mapping. We can and we do map with stereo EEG, but grids, because they cover such an area contiguously, can be really good for mapping. And so there is still a place for them. At our center here at Children's, we do maybe 1 to 2 cases a year of grids. And the hope with all this is that we can get to resection, all right? And so I kind of made this almost like a stepwise ladder, all right? The smallest is like a focal resection, where let's say with your stereo EEG, you found one little spot and there's maybe a little MRI haziness there, and you're like, all right, I'm going to take that spot out. There's 2 ways to do it. So you do a true resection where the surgeon, again, makes a cut, slices that area out, or, and I didn't put this on the slide, there's something called LIT, which is the laser interstitial therapy. And the idea is this, instead of like a cut, the surgeon makes a little burr hole, threads a wire through, and that wire then heats up and sort of burns out the area. And that's called LIT, also known as laser therapy. When the area that needs to come out is a little bigger, that's a lobectomy. The most common lobectomy is temporal lobectomy, where you cut out the temporal lobe, but you can have a frontal lobectomy, occipital, etc. And in theory, it goes, frontal, parietal, occipital, temporal, if you're thinking about where on your brain that is. There's also a lesionectomy. For example, someone who had a stroke and has a scar, and we think that scar is generating the seizure. Sometimes your surgeon may just take the scar out. A small scar might be laser ablated with a LIT, versus a bigger one has to be a open resection. And again, this might not be limited to one lobe, right? It could be frontal and parietal, it could be just frontal, etc., etc. Stepping up from that, we get to the more invasive surgeries, all right? So hemispherotomy is a little more invasive, and that's where they actually disconnect, large parts of the brain, up to half the brain. And so in this case, the brain tissue actually stays in there because that reduces surgical complications. So the part of the brain, and this is for, let's say some kid had a massive injury and half their brain is affected, then we may say, that part of the brain may need to be gone, because it's not like there's one spot we can take out or laser ablate. In which case, instead of taking it out, we may just disconnect it from the rest of the brain and from the rest of the body. And so then even if it has abnormal electrical activity or seizures, it doesn't affect you. And in some cases, though, we do what we call the true anatomic hemispherectomy, where we actually go in, cut out, and remove half the brain. Right? Hemispherotomy, you may have little small parts of the brain left in there. With an anatomic hemispherectomy, you're just taking it out. A little bit higher risk of surgical complication maybe compared to a hemispherotomy, since you do have to take that part of the brain out. But it is kind of the most definitive epilepsy surgery there is. All right. And I do just want to highlight, though, this idea of the anterior temporal lobectomy, because that is probably the most common surgery done. So this is a patient with mesial temporal sclerosis, and you can tell, they've done this, whoever put these pictures online did a nice job of highlighting the hippocampus. And you may not be able to tell, but that hippocampus is smaller than the other side. And it's smaller because it's essentially scarred down. And so, if your EEG and all the data line up as that being the cause, when we see that, we do something called the anterior temporal lobectomy. And you see there in blue, they just cut off the anterior part, which is the front part of the temporal lobe. And in adults, this is one of the most common epilepsy surgeries. It is when all the data is concordant, it has a 60 to 70% chance of achieving complete seizure freedom, which is pretty awesome. Now, other lobectomies, like say a frontal lobectomy, is a little bit closer to say 50%, likelihood, or and other lobes are various numbers. There is no 100% guarantee of seizure freedom with surgery, but what they do is they use other case studies that are similar to yours and decide what is our likelihood of seizure freedom, and then in theory, your epilepsy team would give you a number. There's another kind of surgery I want to highlight called a corpus callosotomy. All right. And so this surgery is usually done in children. And so the corpus callosum is this big, they kind of highlight it. It's essentially it's the connecting wire between the left half of the brain and the right. And so anytime your brain wants to send signals from one side to the other, it sends it via the corpus callosum. And children, especially with certain conditions such as Lennox-Gastaut syndrome or Doza syndrome, these patients will have what we call atonic seizure or drop seizures, where they suddenly drop to the ground. And what we know is that drop happens because of the rapid spread of the seizure from one side to the other. And so you can get rid of that highway. Now a lot of times kids will temporarily lose the ability to walk and control their bladder, but that is something that comes back after a short rehab stint. Modern techniques have an even less chance of adverse effects. So modern techniques for callosotomy are getting better and better. Used to, what they would do is they would make a cut and then pull the brain apart and slice it out. Now what they do is they just do laser ablation. They do a lit. And so this is showing how this surgeon looks like they're going for the back and the front of it and probably going to leave the middle part in place. Most surgeons will take part of it out, but maybe not the whole part out at first. And then they'll go back in if they need to. And so again, they just put their wires in, they make a burn, and they've knocked out a lot of the corpus callosum. And this is very effective for atonic seizures. And in general, we only do this if the kid is able to walk, right? Because if they're crawling, they're probably not going to hurt themselves if they fall. But, these are the kids who wear helmets and who are bashing their face and their nose. And we really want to protect them by doing surgeries like this. And so now I just want to take a minute and this is kind of the last section because I want to leave time for questions and talk about neuromodulation. So I'm going to start with VNS. So VNS is the first neuromodulation device that was approved for epilepsy. It was approved in the early 90s. And the idea is that they put a battery here under the skin. A wire snakes up under your skin and wraps around the vagus nerve. And then the vagus nerve kind of is a two-way street. From the brain, it sends signals down to the heart to control your heart rate, but then it also sends signals back up. And what we know is that when the vagal nerve connects back to the brain, it is heavily involved with neurotransmitter regulation, especially things like serotonin. And so a vagal nerve stimulator, in its standard settings, because a lot of times in patients who are having a lot of seizures, we go off the standard settings. It fires for 30 seconds, like, and then takes a 5-minute break. 30 seconds, 5-minute break. And it does this constantly, all day and all night. And the idea, and then if you feel a seizure coming on, one, it has a heart rate detection, so it will deliver an extra stim in that case. Or it comes with a magnet and you or your caregiver can swipe it and deliver an extra stim in that case. And that extra stim can help break up a seizure. And a lot of families find that very effective. But the truth is, the best thing about the VNS isn't necessarily it breaking up a seizure. It's this idea of neuromodulation. Is that this constant firing and changing the neurotransmitter balance in your brain will lead to long-term benefits. And so it actually takes months to even over a year to really see the full benefit of a VNS. One, because we have to slowly titrate the electricity up, and we make adjustments as we go. But again, it's this idea of it's kind of modulating those neural pathways. All right. And again, we've had experience with this since the 90s. The nice thing about VNS is it also has a FDA approval as like a third or fourth line therapy for refractory depression. And so it's not, some of our anti-seizure medications actually can make mood and depression worse. And so it's actually really nice to have an option for treating that doesn't do that actually maybe can help your mood or depression. It has some off-label uses in migraine, although that is fairly off-label. And then it does come with an increased risk of kind of worsening existing sleep apnea. So there are some limitations on who can get this. The next one I really want to talk about is DBS. So right now, this is approved in adults, and with some but not much off-label use in children. And just like the VNS, it's another one of those that like fires, takes a break, fires, takes a break. But there is no magnet. It doesn't. And so with this one, again, it's just constantly neuromodulating. And this is approved for placement in the anterior nucleus of the thalamus. All right. And so the thalamus is a deep, deep structure. And it says here, deep in the brain. And the idea of the thalamus is it's kind of the relay center for everything. All right. Anything that goes from your brain to the rest of your body, body to brain, often one side of the brain to the other, has to run through the thalamus at some point because it is that relay center. And what this is best for, although it has been used in other epilepsies, so this is not limited to it, is temporal lobe epilepsy, right? So your temporal lobe is here. The temporal lobe has a very strong connection to the anterior nucleus of the thalamus. And so the idea is that by modulating, right, not necessarily like stopping in a seizure extract, but modulating over time, in that anterior nucleus of the thalamus, you are changing the network in that temporal lobe to make seizures decrease. And they had a really big trial that showed great effects with this. And so then your neurologist has, just like VNS, your neurologist has an iPad, and they can program it and change programming around, try and get better efficacy. It does not measure. Now, I will say that last I heard that DBS is very, very close to getting FDA to approve a change to their device. So currently all it does is stimulate. But in the future, and everything I've heard has been encouraging, they will have it where it also reads, where some of the electrodes on it will be this normal stimulating electrodes, but then also some electrodes will be EEG electrodes. And so it's actually going to be measuring EEG data and delivering extra stimulation when it detects a seizure. And so that is super exciting. And that is hopefully coming down the pipeline soon. And again, currently it's used in the anterior nucleus. I do know that there are multiple centers, like many centers, who are trialing and working on off-label use to implant it in other thalamic nuclei, right? Because if the ANT nucleus is for the temporal lobe, there are other nuclei that maybe connect to the back, like the pulvinar nucleus, or more diffusely frontal and diffuse, like the central median nucleus. And so it is being tried, other centers are trying this in other nuclei. And then there's the RNS system. All right. In full disclosure, I have a little more experience with this because our surgeon usually does RNS over DBS. And so that's just what I have a little more experience with. So this is responsive neurostimulation. And this is a little different. Whereas DBS and VNS have the battery here, with RNS, the battery actually kind of is embedded in the skull. And RNS has a little bit more flexibility. So you can use it like a DBS. You can actually implant it in the anterior nucleus. You can implant it in the central median nucleus for more diffuse widespread epilepsy. or you can implant it on what we call the cortex, more the outside of the brain, or even some of those other deep cortical structures. And so one of the most common uses of RNS is actually what we call bitemporal epilepsy. So temporal epilepsy is one of the most common in adults. And unfortunately, a lot of patients with temporal epilepsy eventually will start seizing from both their temporal lobes. And in that case, they can't do surgery because you can't take both temporal lobes out, or else you can't form new memories. So if that's the case, you're just no longer a surgical candidate for like an anterior temporal lobectomy. But you could put an RNS in and put a probe in each temporal lobe. And in the trial data, the long-term data at 9 years out, there was an average of 80% seizure reduction, with 75% of patients having a significant seizure reduction, and I think close to 30% being what they call super responders, with a over 90% seizure reduction. Or if it's here, you can have it just put a little, instead of a deep probe skewering, you could put like a strip of stimulators on other parts of the brain. And so this is really exciting. There's 3 ongoing studies for RNS right now. The first is the Nautilus study, which I personally, as a pediatric neurologist, am very excited about because it's trialing for generalized epilepsy, right? So the idea of focal epilepsy, this one spot and spreading, is great when you can put like a little strip or like a little skewer on that. But generalized epilepsy, which is the whole brain at once, obviously that doesn't work. And so, but with this, what they're doing with the Nautilus study is they're implanting the central median nucleus of the thalamus, because we know that generalized epilepsies run through that. There's a Lennox-Gastaut syndrome study, which just kind of, again, looking at that central median nucleus implantation, because those patients have very widespread epilepsy networks. And then they're also running one for teenagers with focal epilepsy. So for me, this is actually really pertinent to my practice in children with, because I have a lot of children in my practice with Lennox-Gastaut and intractable epilepsy. And then finally, there's another device that, I've heard about it at several meetings, and I know it's being studied a lot, but at least as of right now, I don't hear anything about it hitting the market soon. I'm going to be quite honest with you. And that's transcranial magnetic stimulation. And this idea is that you have a stimulator, and instead of having to implant or anything like that, you just often most of the trials are doing it with posterior stimulation, is that you hold it to the skull and it sends magnetic fields, which again, if you remember from our MEG, aren't blocked by the skull. And again, it neuromodulates in that manner. And I know there are ongoing trials also, I think, with this in depression, autism, certain spastic genetic disorder, certain genetic disorders they're working on treatment with this. And I think in Eastern Europe, they're working on several epilepsy trials, but I'm not aware of any trials ongoing here in America. And so that is how we treat epilepsy. It's meds, it's diets, surgeries, and devices. We've come a long way. The new frontier is new things with our devices, new meds that come out, or hopefully coming out. And of course, genetics is really kind of that new frontier for us here in epilepsy. So I was hoping to give us 15 minutes for questions, and I think I did. Are we taking questions?
Yes, no, thank you so much, Dr. Terrill. That was a great presentation. I actually have some questions here right now for you that
Great.
people put in the chat. So the first question was, is there a significant difference between name brand and generic medication?
That's a great question. So as far as the chemical element itself, so if you were taking generic lamotrigine versus name brand Lamictal, there's the chemical itself has to be the same within a very, very high degree of certainty, meaning it may be 1% different dose, but the FDA actually they spend a lot of money to regulate that very closely. All right. Now, what can be different is the other chemicals used. So every medicine is not just the active ingredient. You have to have, if it's a pill, you have to have binding agents. You have to have preservatives to keep it shelf stable. All right. If it's a liquid, you've got to have sugar in there so the kids will actually swallow it. right? And so any of those non-active ingredients, the FDA, as long as they're safe ingredients, the FDA kind of lets them do with it what they will. And so in the active medicine is not different, but some people just don't tolerate different types of other ingredient. And so I've had some patients who just get upset stomach if they're not a name brand. I've had some patients who are like, I hate name brand, I need generic. And so it really depends on, I'd say 99% of patients, it doesn't matter one way or another, because all that matters is the active ingredient. There are patients though that just can't tolerate, maybe the sugar concentration is wrong for them or something like that,
Gotcha. Thank you for that. Another question someone put was is there any additional information on Turner syndrome and epilepsy?
Turner syndrome and epilepsy. To my knowledge, I don't. Turner syndrome with epilepsy, you treat. I hate to say just like any other epilepsy because every patient's different, but in a way, kind of, you treat it based on the seizure types that present, right? You might use a focal drug for focal seizures, generalized drugs for generalized seizures. And there's nothing that would prevent a patient with Turner syndrome from, say, getting evaluated for an epilepsy surgery or a neuromodulation device. A lot of genetic conditions come with a risk of epilepsy. Turner syndrome is not like super, super high, but those patients can definitely have seizures, right? It's not one of our highest risk genetic conditions, but absolutely, if you or someone you know has Turner syndrome and has seizures, they need treatment. But I have to double check the literature, but to my knowledge, there's not like particular medication you have to use.
Okay, gotcha. Okay, so this one is maybe like a two-parter question.
Yeah.
For the Endeavor trial mentioned, will it be a one-time treatment and will it help stop seizures?
Yeah, that's a great question. So it would be a one-time treatment, is what they are hoping for, is a one-time treatment. And then they are also, and then the idea, and then their primary endpoint is seizure reduction. I think they are also hoping to rescue the development because in Dravet syndrome, unfortunately, there is developmental regression and developmental disability that comes as part of that syndrome. And so from what I've read of the trial, is that their primary endpoint is seizure control, and but they are, I think, also hoping to rescue development as well. And I'm so sorry, I forgot to put it in the slides, but also for Dravet syndrome, I know there's been a trial on antisense oligonucleotides also for Dravet, but the information I found on that was a little out of date, and so I didn't want to put it because I'm just not sure where they are in that trial, if they were actually meeting their endpoints or not. And again, Dravet is such a heavily studied epilepsy because of the seizure burden.
Gotcha. Okay. So next question, what medication is usually prescribed first to treat myoclonic epilepsy? And once meds are taken, what's usually the expected seizure reduction rate while taking meds? Is it possible to go seizure-free after taking these meds?
Yeah, so the medications most commonly, now this is not an exhaustive list, all right? I just want to be very clear. But a lot of people will use things like levetiracetam, which is Keppra, valproic acid, which is Depakote, clobazam, which is Onfi, zanisamide, which is Zonegran. I've seen some people in more refractory cases use Epidiolex, fenfluramine. Another medication I didn't mention earlier called felbamate can be used for refractory myoclonic seizures. What else? I saw some data on cenobamate, but I'd have to go double check the literature. And brivaracetam, which is Briviact, can also be used. Brivaracetam is sort of just fancy Keppra. And so it really depends on the scenario. If it's certain genetic epilepsies, if I'm going to be honest, the rate of seizures, of true seizure elimination, like a genetic myoclonic epilepsy, is not that high. Not to say we don't try, but it's not that high. In more benign myoclonic epilepsies, such as like a juvenile myoclonic epilepsy, 85% of those patients will go seizure-free if it's juvenile myoclonic epilepsy. And so, yeah, that's not an exhaustive list. There are other medications used, but those are some of the more commonly used ones. And it really depends. So all comers epilepsy, 50%, about 50% of the time, the first medicine is the right medicine. That does mean 50% it's not. And we achieve seizure freedom in somewhere between 2/3 and 3/4 of patients, depending on which country ran the study. All right, I think in Northern Europe, they keep quoting 75%. I hear more closer to 2/3 here in America, but some of the newer studies look a little better as we've gotten better drugs. And so, to me, myoclonic seizures are probably in that 2/3 to 3/4 range of should you expect seizure resolution.
Gotcha. Okay. Next question. The data is inconsistent after years of trying meds, EEGs, MRIs, and even MEG. Would the neuromodulation options ever be considered?
Yeah, and so we do consider that epilepsy surgery, and those tests are usually used to hope for epilepsy surgery, are a more definitive treatment. But sometimes we can't find the focus, right? We can't find if we can't find the focus, then in that case, neuromodulation is definitely an option. Or if the seizure focus is like, say, like sitting on top of your language center, well, obviously we can't cut that out. And so in those cases, especially, a lot of times the RNS, you need to have some good hypothesis of RNS and DBS, you need to have some reasonable hypothesis of where the seizures are coming from to know where to implant. And some people, and a lot of times you use actually that stereo EEG to plan where you're going to plant your RNS. VNS, if it's a seizure, VNS kind of just treats any seizure, right? Especially because it's not specific. And so a lot of times if you're not confident on your localization of the seizure, VNS is a great option. It's old, but it works.
Okay, and then another question. How do you approach medication adjustments if a patient is still having seizures?
Yeah, so my usual approach, so let's say I have someone, I put them on one medicine, right? If they keep seizing, what I do is I try to maximize the first medicine before I add another. And the reason being is that the fewer number of medications is generally associated with a higher quality of life, even if the single medication is at a high dose. In general, less number of meds, better quality of life, even if they're at higher doses. And so depending on the medicine, I'll push it up to the max per weight. I deal with kids, so it's all weight-based. And when I'm kind of getting near that, will check drug levels to see if I still have room to go up, because a lot of kids are hypermetabolizers where they metabolize meds very quickly. If I'm pushing the drug up high, and either I'm limited by the blood level or by side effects, at that point, I add a second drug. And I usually don't take the first one away unless I can stabilize the patient, right? And so in that case, and so again, I kind of do the same exercise, push the drug up and see where we are. And then at that point, there are patients I have to put on 3 or more drugs, but I try to keep when I can, I try to keep it to 2 drugs or less. And so I might try switching 1 or 2 of the drugs out for other drugs. I might pick drugs that have synergy together. For example, clobazam and stiripentol for Dravet syndrome have a synergy. Depakote and lamotrigine synergize. So sometimes I'll try and pick meds that synergize, or I'll pick meds that interact in certain ways together. Or I might pick a sodium channel blocking med and a GABA blocking med, so I'll try and mix and match in that way. Some patients, and then that's kind of my approach, right? Try to keep it to 2 when I can. Sometimes I have to do more if there's no other option.
Gotcha. Okay. And then one more follow-up question. How do anti-seizure medications interact with other medications and supplements?
That's a great question. So there are a few supplements, I think St. John's wort and a couple others that affect anti-seizure medications. So never start a new supplement without talking to your physician or looking it up in an interaction checker. Anti-seizure medications are most famously interact with oral contraceptives. And so when I have like a teenage young lady that I'm putting on seizure meds, I usually run it through an interaction checker, and like counsel them because they may start those a contraceptive between my visit and the next visit with me, right? And so I do warn them if they're of that age, like, hey, this may make contraceptive medications work less effectively. Or if you start an oral contraceptive, it may make your seizure drug less effective. And that's really important because that turns into some very big life changes if you mess that up. I think it can interact with some of the drugs. Some seizure drugs interact with each other. You have to watch for. I think some antidepressants it interacts with. One or two antibiotics that I always have to double check them, to be quite honest, because I can't remember those off the top of my head. But those are the
Gotcha.
big ones.
Gotcha. And what would you say to someone that struggles whenever they maybe miss a dose or stuff? What do you recommend when people are missing dosages?
So the nice thing about today is that we all have cell phones. And I tell people cell phone, like set alarms, set alarms, set alarms. If you're the kind of person that will snooze an alarm, set 3. All right. Some people really like having like a pill box, like that, Monday, Tuesday, Wednesday thing, AM, PM. Some people really like that because, and then they put it somewhere like where they have to like they put it like their keys next to it so then they don't forget, right? So then if they see their keys, they're like, oh wait, no, I gotta take my meds before I go to school, right?
Gotcha.
In my world with pediatrics, I do caution parents that like just because your 12-year-old is responsible does not mean that they can be responsible for their medications. Maybe when the kids start getting to 16, 17, 18, I'm like, all right, let's start giving our teenagers some responsibility with supervision, right? But usually I say phone alarms, pill boxes. Some people need some like sort of physical reminder, like a little thing they have to do to remind themselves. And the truth is, it varies by patient. Some patients, a single missed dose will put them in the hospital from a seizure. Other patients can miss like 3 days and be fine.
Yeah.
It's so variable patient to patient.
Gotcha. And is there any kind of like tracking apps or wearable devices that you use that you recommend to patients?
For tracking seizures. So there's a company that makes a product called Embrace, and they've got some new product out that I've already forgotten the name of. And these are wearable watches that are actually FDA approved for seizure detection.
Oh, okay.
Now, the caveat being that they are expensive, not always covered by insurance, and often come with like monthly subscription fees to use the software. A lot of what I tell a lot of my families is, honestly, just get a baby monitor. I know that sounds kind of silly, right? And it sounds kind of blasé, but like a short, like 10-second little staring seizure at night isn't going to hurt your child. We want to be able to watch for the big seizures, the convulsions. And so a baby monitor will help you with that. There are cameras, which I don't think have FDA approval. They're just things you can buy that are marketed as, motion sensing to help you know when your kid is seizing. I haven't checked recently, but last time I checked, none of those had a true FDA approval. I think they were marketed as consumer devices, so I don't think they needed one. And I always just tell patients, like, you're not going to get insurance to cover this, so use it at your own risk, essentially.
Gotcha. Okay. And then one last question that just popped up. Is it possible for MTS to come back after a lobotomy?
Like, mesotemporal sclerosis after a lobectomy?
Lobectomy, excuse me. Sorry.
Yeah, no, you're good. So let's say someone does an anterior temporal lobectomy on you. That MTS cannot come back because that anterior hippocampus is gone. The one caveat is that sometimes temporal lobe epilepsy gets kind of weird, and if you've had long-standing seizures from one side, it can actually seed the other temporal lobe to generate seizures as well. And there is a risk that the other temporal lobe could generate seizures in the future. And so, that's why like giving really good descriptions of seizures to your doctor is important so they can make sure that there's no discongruity. Like maybe actually it may not just be all this one, maybe it's this one as well. That is not common. It can happen. It is not a reason to avoid a temporal lobectomy in general, right? If all your data says it's this side, then it's probably not, then that's not a huge risk. But some of these patients, it's only maybe some this side, but some of the data starts kind of leaning over here. I'd have a little caution. Not saying no to surgery, but caution.
Gotcha. Alrighty, well, we are at the end of our time. Thank you so much, Dr. Terrill, for coming on and being here and giving a great
Yeah.
presentation. Really appreciate your time.
Absolutely.
Awesome.
Absolutely.
So just as a final reminder, we do have our next session on July 2nd about transition from pediatric to adult care. And we'll send out reminders. Follow us on Instagram or Facebook to get registration links. And I hope everyone has a good evening. Thank you so much.
Bye.
Bye-bye.